Morning, everyone. Lighten up. Come on, let's have some energy in the room. How many people are radial primary? Do most of their PCIs radial? Oh my gosh, right. So that's incredible. So actually, you're a non-representative audience then, because the NCDR, the latest, says about 35%. I guessed about 65 to 70%. Fantastic. No disclosures. We'll start with some questions, and we'll go through these again at the end like you've been doing. So compared to transfemoral PCI in STEMI, transradial PCI is associated with all of the following except. So one of these is wrong. Okay, good, a split there. PCI in an 85-year-old man is complicated by an initial inability to advance a wire and catheter beyond the antecubital fossa. The patient complains of some discomfort in that area and an angiogram is performed, so that's the right thing to do, right? You take a picture with the contrast injected via the catheter. Okay, this is the angiogram. The white arrow is the catheter tip, and the question is going to be about the yellow arrows. What are they pointing at? The profunda brachial, a high takeoff radial, the anterior interosseous artery, a recurrent radial artery and loop, or recurrent radial artery. Okay. A meta-analysis of radiation parameters in randomized trials of radial versus femoral PCI. So randomized trials, they're evenly split, showed total fluoroscopy times were higher in radial, similar, or lower in radial. This is fluoroscopy times total time, not dosage, total time. All right, excellent. We'll come back to those. A 53-year-old female with class 3 angina and abnormal stress test is referred for angiography. A hydrophilic sheath is placed. Heparin 2,500 units is administered. There is some resistance to catheter passage in the forearm, and at completion the sheath is removed, although force is required. That's a spasm. Manual pressure is applied for 30 minutes with successful hemostasis. The next day, the radial artery is found to be occluded. So which of the following is not associated with radial artery occlusion? So 4 of these are predictors and associated factors, and 1 is not. Good. Okay, so 3 learning objectives today. We'll look at the clinical outcomes in the studies, some technical aspects with evidence base, and then some basic troubleshooting. I think each of these objectives are very testable, and we'll try and focus on the testable aspects. So this is registry observational data, so by definition there's going to be some selection bias, but this looks at radial versus femoral PCI and bleeding complication a few years ago now, but you'll see here that femoral in every one of these subsets is associated with a higher risk of bleeding compared with radial in red. Now remember the selection bias aspect, but the point of showing you this data is showing you that the big difference here is in STEMI and to some extent also in non-STEMI. So this is really the first clue from the data that it may be the acute coronary syndromes that have the most benefit of radial compared with femoral. And that pans out in the subsequent years in the randomized trials. And I want to look at 2 of the randomized trials. There have been 4 pretty decent ones, but I want to look at 2 of them. The Matrix trial, which is the biggest trial, and let's look at the data here. So 8,400 patients with acute coronary syndromes, I think 48% STEMI, 52% non-STEMI, so pretty good representative sample. And their co-primary endpoints at 30 days both favored the radial approach. mostly a European trial, but this showed that there was a 1.5% absolute risk reduction in the composite endpoint of death, MI, and stroke, and in the composite net endpoint of which included major bleeding. So this is impressive. And I'll say now, if this was a medication, an intravenous bolus given at the time of PCI, there would be no question that we'd all be using this, right? I mean, a 1.9, 1.5% absolute risk reduction in major events with no clear downside. Now, this trial, like every other randomized trial of radial versus femoral, showed higher daughter balloon times with radial, between 3 and 6 minutes longer on average with radial, and someone asked that question earlier on, and higher rates of crossover. So crossover means you fail radial access, you have to cross over to another site, and most people still will not cross over to the other radial, they'll cross over to a femoral. So despite those two adverse features in every randomized trial, the signals are always still in clinical endpoints favoring a radial approach. A quick look at one other randomized trial, and I highlight this one because this was the first big trial that suggested or that confirmed what people had suspected about benefit. This was the Rival trial published in 2011. So this wasn't just ACS, this was all comers who were randomized to radial versus femoral. And we often forget in this world where we're all using radial that the first trial was actually negative. The primary endpoint was negative, and the reason it was negative was that the definition of bleeding in Rival was really strong. Multiple units of blood transfusion required to have a bleeding event. If you use any of the other bleeding endpoints by other trials, then this was a positive trial, but by definition, this was primary endpoint was negative, as were the key secondary endpoints. Again, the big thing that came out of this trial was the pre-specified endpoint of STEMI. STEMI markedly favored the radial approach in terms of a composite endpoint, 40% relative risk reduction, and a 50% relative risk reduction in mortality. So this was a really interesting findings with spectacular numbers needed to treat. Again, if this was a pill, if this was an IV push, this would be a no-brainer. So that was the Rival trial. We discussed the Matrix trial. This is a meta-analysis of the acute coronary syndrome randomized trials, again randomized 19,000 patients, all showing a signal for clinical benefit of radial versus femoral. Again, each of them individually showing a longer daughter balloon time and higher rates of crossover to an alternate access. This made it into the European guidelines, and this is Class 1A in 2018 as well. It's not yet a US guideline statement, but I think incorporated, but I think that will happen soon. So mortality benefit, does that make sense that you use a different access site and you can have a mortality benefit? Well, the randomized trials were fairly concordant in this. There's certainly none the other way around. We'll discuss why that might be, but I think it's worth highlighting the timing of mortality benefit that was shown in the Matrix trial and in others. It was early. In my mind, that makes sense. I mean, if you're going to say the benefit is because of a switch in access site and it was spurious, then you might say, well, the benefit will come at any time. But the fact that it came early makes it more believable as a hypothesis of a benefit with radial artery access here. And you'll see the benefit here is early. How might radial access reduce mortality? Well, it's not known. This is all speculative. It makes sense to put bleeding first and foremost, a direct effect of the blood loss. You know what happens when someone's bleeding, right? We all think about stopping antiplatelet therapy, so maybe that's one of the reasons why femoral fared worse here, or the effect of transfusion, but none of this has been proven. These are all speculative aspects. How about atheroembolization? I think this is a particularly intriguing hypothesis that's now getting some traction. We know that if you look at the aorta, most of the plaque in the aorta is in the abdominal aorta. There's actually not much in the thoracic aorta. So if you're going up from the femoral, there's more likely to be scraping of plaque than there is from the radial. And as an aside, the recent sub-study of Matrix, the renal sub-study, showed that in a randomized trial, that radial access was associated with a much lower risk of renal worsening compared with femoral, lower risk of progression, lower risk of dialysis. And it all fits with this atheroembolization hypothesis that you're doing less scraping from the wrist, therefore less renal injury. And some speculate, well, maybe this is a less is more. We know that when you're in the radial, you're much less likely to upsize to bigger bore interventions. Well, perhaps that is a mechanism of benefit. Maybe you're less likely to do super complex PCI from the femoral. You maybe feel emboldened and putting in 312 French sheaths and doing all sorts of fancy stuff that Dr. Sandu just showed you. And you're maybe less likely to do that with the radial. Again, these are all speculative. And then this final aspect is important to discuss. We know that from all the studies that the benefit was greater in high volume centers and operators, and it stresses the importance of systems of care and multidisciplinary care that may be underlying some of the benefit of radial access. So key points from a clinical aspect for the boards are that radial does reduce mortality in acute coronary syndrome, particularly STEMI, from the meta-analyses. We know there's lower bleeding, vascular complications, and major adverse events. We do not understand the mechanism of mortality benefit, but there are those hypotheses. And these benefits are despite the downside of radial, consistent, concordant downside of higher daughter balloon time and higher rates of access crossover. So there's the benefits from a clinical standpoint. We know not everyone is a believer. One of our attendees, regular attendees, refused to come this year because of this, but he did tweet this morning. And I thought it's only fair in the interest of balance that we put up his tweet. He's a strong believer in alternate access. All right. Let's talk about a couple of technical aspects of radial artery occlusion first of all here. So here's some basic bullets. We know that radial artery occlusion occurs, it still occurs, and this is depends on how you look for it. If you look for it with ultrasound, you'll see higher rates. If you look for it with clinical assessment, you'll see lower rates, but it's almost always asymptomatic. The predictors here, female, spasm, and small arteries. Half, or in fact probably more, will recanalize by 30 days, which I think is interesting. To properly assess for radial artery occlusion, you have to occlude the ulnar artery. This is a common error and may have underpinned some of the low rates of occlusion reported in registries. So you can feel pulsation in the radial artery if it's occluded because, of course, the connections from the palmar vessels. So you can feel a pulse. Maybe it feels weaker than it used to, but you'll be fooled to think it's patent unless you occlude the ulnar artery, and then that pulse may disappear. If it disappears, that confirms the radial is occluded despite pulsatility. That makes sense? Okay. We know that adequate anticoagulation reduces radial artery occlusion. This has been shown now by a number of groups, and here's what is recommended. Unfractionated heparin at those doses, or 5,000 units. You know, there's a lot of discussion. Should we, say, is this wrong, 5,000 units? If someone's 120 kilograms, is that going to make enough? So many people will give a weight-based bolus. We know that lower doses are not adequate at reducing radial artery occlusion. Intravenous or intraarterial, there's one study showing that you can give intraarterial low molecular weight heparin, and another showing that bivalirudin is also an acceptable alternative. The biggest thing is patent hemostasis, so maintaining radial flow during radial artery compression. So here's the first study that looked at this, and it showed that a traditional hold, which is a non-quantitated hold where you just press the radial artery until you get hemostasis, was not as good as patent hemostasis, meaning that you maintain flow through the radial artery while preventing bleeding. Patent hemostasis. How do you do patent hemostasis? This is the commonest way now. Put a compression band on, release the band till there's bleed back, add some extra air, and then do the reverse Barbeau test. Let's go through this. You put a plethysmograph on the index finger, and again you have to occlude the ulnar artery. You keep on removing air from that band until you see a waveform on that first finger. That means you have flow from the forearm to the hand through the radial artery. So that's the way you have to assess it. Plethysmographic reverse Barbeau testing. Anyone do the Allen's test pre-radial? Hands up for those that do the Allen's test. Okay, still a few. Just as you know, as a background, there was a study showing that there's no benefit to doing the Allen's test. It does not predict radial occlusion, doesn't predict ischemia, but I know that some people still do it, and I think that's fair. A new thing that I will mention that could potentially be board testable, it was published more than a year ago now, is ulnar compression and radial occlusion. Here the theory is that we know, as I've showed you from that data, that maintaining flow through the radial artery prevents occlusion. We know that if you press on the ulnar artery, it diverts blood down the radial, sort of forces it go the other pathway. And the question that these investigators asked was, well, does ulnar compression reduce radial artery occlusion? So a large randomized study that compares standard patent hemostasis versus patent hemostasis in addition to ulnar compression. And let's look at this together. So the y-axis is radial artery occlusion, and the red bars are what we all typically do with patent hemostasis. So there's a fairly high rate of early occlusion, as assessed by ultrasound, and at 30 days, really a pretty impressive recanalization in standard patent hemostasis. But look at the impact of the addition of ulnar compression. Incredibly low rates of occlusion at baseline that get even better. So this was highly significant. Big p-values, little p-values, I should say, and there's some new technology that's been developed that may assist in doing this with a single device, because right now doing this is a little bit clunky. I borrowed these videos from Sam Pancholi, who's led this field, and this is how he does it. This is more of an FYI, I doubt they will be testing this particular aspect. So he rolls up a needle in a plugget of gauze here, and then he puts a band on over the ulnar, palpates for it, and he puts that rolled up gauze with the needle plastic covering inside it over there, and tightens up the band to compress the ulnar artery. And you'll see the sheath is partway out on the radial. And then he pulls out the radial sheath in a standard fashion. Just one thing to note. What Sam Pancholi does, he opens up the sidearm every time he pulls out a radial sheath, no matter what method of using it. And he says, well, that maybe lets the column of static blood drain out. That sort of makes sense, right? Maybe if there's any thrombus there, it'll come out as you're pulling the sheath. So we've started to do this now. Didn't think about that before. And then uses that ulnar band to force the blood, divert it down the radial artery, and it got that very impressive data. A little clunky, but I think this may be an important thing moving forward. All right, the second technical aspect of radiation, and we had a question on this. Here's the bottom line, is this. It does favor the femoral. No two ways about it. This meta-analysis published in The Lancet 3 years ago showed that from total fluoroscopy times are lower in the femoral compared to the radial. This was confirmed in the RAD matrix trial, higher radiation times with radial compared to femoral. This RAD matrix, which was a sub-study of the matrix trial, did show that the impact to procedural volume, so the higher volume operators and centers had closer radial femoral approximation in terms of procedural dosage compared to the lower volume centers and operators. This is a nice graph that showed that over time, looking at all the studies, that clearly there is improvement. The radial is now approaching femoral in terms of fluoroscopy times, but it's not there in the meta-analysis. And I think it's a very testable question that radial is still associated with higher fluoroscopy times, but then with more experience, that difference is diminishing. So key points from radiation: higher times improving over time, higher operator radial dose in the RAD matrix sub-study, that's worth noting. The difference is definitely reduced with experience. Everyone wants to know about the left versus right, and there have been 5 randomized studies of left versus right radial, 3 of which looked at radiation, and there's discordance. One showed no difference, one showed favored the right radial, one favored the left radial. So I think there's room for discussion on that, and it may be techniques, but certainly there's no concordance as yet as to choice of which side for radial. All right, let's go through those questions, and then we'll do some troubleshooting together, back and forth. So let's go through these again. Compared to transfemoral PCI and STEMI, transradial is associated with all of the following except... Fantastic. Fantastic. So we'll just go through these. So we know reduced vascular complications, decreased bleeding, mortality is lower in the meta-analyses and in 2 of the 3 randomized trials. We know there's higher crossover from radial, and this is correct, there is a similar frequency of stroke with radial versus femoral access. All right. question 2, we can just go to the picture here. So this is the catheter tip, and here is the question, and we'll go in just a moment here. You know, I'll tell you what, we'll not ask this question. I just want to show you this. So this is a radial loop. I think many of you got this, and this is the accessory radial artery. So with radial loops, it is pretty much 100% true that you will also have this accessory radial artery. And this is important. It's important to know this, because if you think about it, when you're getting access, your wire wants to go right up here. It doesn't want to go around the loop. And you may not know that there is an accessory radial artery, and this may be small and thin and peter out up here. So if you don't know that, if you feel some resistance of the wire, but you think I'm going to keep going with my diagnostic catheter, there is a high chance of catheter entrapment in this accessory radial artery. So know the association of the loop and the accessory. We won't ask this question. Here's a couple of clues that you might be in an accessory vessel. This is supposedly a J-tip wire, but it's straightened out. And this is a squished 3mm J-tip wire. So this tells you you're in a small vessel. There is no way the brachial artery should squish your wire or straighten out your brachial. Brachial arteries are huge, right? They're 6mm. So if you see this, you're in an accessory radial artery. So you stop, you take a picture, you figure out the anatomy, and go around the loop if you need to. Meta-analysis of radiation parameters. Let's vote on this one again. A higher in radial, similar in both, or lower in radial? Excellent. Excellent. This is the 93 kilogram, 53-year-old female that had occlusion of her radial artery the next day. So it was a spasm, heparin, and occlusion. And we'll go through these. We don't need to vote on this. So the 4 in pink there are predictors of radial artery occlusion. We know that if you oversize the sheath with respect to the radial diameter, and if you go 765, there's more occlusion, middle, less occlusion in terms of French size. Spasm is a predictor. Anticoagulant regimen, if you don't give enough heparin at baseline, there's definitely higher rates of occlusion. And the patent hemostasis that we discussed, this has no impact on occlusion. All right, so we've done some basic QA stuff. So let's do a little troubleshooting together. So the story is here. Your diagnostic went fine. You've got some pictures, and you now go with a guide, and you meet resistance with the guide above the elbow. You can turn to your tech, your nurse, and your fellow, and you can tell them exactly what's going on. Anyone? Before you even take a look. Fantastic. High takeoff radial artery. So this is the picture here. The key point here is there is only one vessel at the elbow, right? This is the radial artery. What you should see, let's go and see what you should see. Here's a normal anatomy. What you should see is the radial artery going to brachial, the ulnar artery, and the interosseous artery. What we see here is a single artery. So if you see a single artery at the elbow, this is a high takeoff radial artery. And we can see more clearly with a movie here. You see here, if you watch late, we'll now see the brachial filling down here. So let's run this again. So the radial connects somewhere up in the arm, and now you see filling down over here. So this is a high takeoff radial artery, typically tortuous, especially in the upper arm, fairly narrow caliber. So your diagnostics slip through this fine, but now your bigger guide with a bigger lumen, more likely to scrape and catch on tortuosity, and that's exactly what's going on. You can predict this just on the clinical story. So here's the connection here, the radial from the upper arm into the brachial. Here's another example of a high takeoff radial, but a much thinner vessel here and more tortuous up at the top. And we discussed here the issue is with the guide, typically raise the edge of this guide over a wire. You can smooth out that edge with this balloon. This is called balloon assisted tracking, so this reduces the traumatic nature of the guide tip. And here is how this is done. Here's a guide. There's a 2mm balloon inflated at a few atmospheres, and this can be used very atraumatically in multiple circumstances to track through tortuosity, narrow vessels, curves, and whatnot. And this can be used successfully to assist with guide passage. All right, resistance at the subclavian. Is this subclavian occluded? Hands up for yes. Okay. No, no one said yes. So this is not occluded. You're just meeting a wave of blood coming towards you. That's why it looks occluded. You see there's antegrade flow in the mammary, antegrade flow in the vertebral artery. This is not occluded. This is just a twisty, turny, tortuous, innominate subclavian access. And how do you manage this? Deep breath. Deep breath. You know this. Deep breath straightens it all out. Okay. Deep breath is your friend. I'll show it once again because it's very satisfying to me to see this anyway. There you go. Bang. All right, very good. You should know that 2 randomized trials conducted at 2 sides of the world showed that the predictors of subclavian innominate tortuosity on the right were 5'5" or less, 75 years or more in age. So older, shorter are more likely to have innominate tortuosity. Certainly in my practice now, I do a lot more left radial than I used to. In this demographic, certainly the combination of the two, much more likely to choose left radial access. Get the sense sometimes that hypertension is a predictor, that female is a predictor, but didn't turn out in these 2 randomized trials. But this is the 5'5" or less, 75 or more, strongly consider left radial access. So final slide. Just a few things: bleeding benefit, mortality benefit in STEMI, how to prevent radial occlusion, some simple anatomy, and some troubleshooting.